Hi, everyone. Welcome to this episode of WHAMcast by the Women's Health Awareness Movement, where we shine a light on important and often overlooked issues in women's health. So my name is Mina. I'm a representative at WHAM.
And my name is Allison. I'm the WHAM president.
And today we're honored to be joined by Dr. Andrew Zakhari, obstetrician and gynecologist at McGill University Health Center, otherwise known as MUHC. Dr. Zakhari has advanced training in minimally invasive and complex gynecology surgery, including endometriosis care. He is the co-founder and co-director of EndoCares, the Center for Advancement of Research and Surgery, a pioneer specialty clinic at the MUHC managing complex endometriosis cases.
As well as Melissa Shang Leen, who is a registered nurse with over 20 years of experience in gynecology, gyne-oncology, and uro-oncology, as well as radiation oncology. She's also the EndoCares clinic nurse navigator, acting as the point person for patients and guiding them towards the appropriate resources to deal with their symptoms of endometriosis.
We're very excited to have both of our guests with us today to discuss endometriosis, so what it is, why it's so often misunderstood and underdiagnosed, and how we can work towards better care and awareness.
So, Dr. Zakhari and Melissa, welcome to WHAMcast.
Thank you so much. Happy to be here.
Yes.
To get things started, maybe could you explain what led to you to focus on this work in endometriosis?
So maybe I can start with this one, but in OBGYN, there's a lot of different patient populations that we work with. So there's those who are pregnant, those who are older with some types of cancers, and there's also those with a lot of benign conditions, so non-cancerous problems like fibroids or endometriosis, ovarian cysts, that sort of thing. And we find that those with endometriosis specifically often need really specific tailored care, which is difficult to get to. And there was a clear, need for this sort of service in our area as well as across Canada. So besides being a very interesting field of study with very interesting surgeries, it's also a much needed resource that we thought was a good opportunity to build for our patients in our community.
And what about you, Melissa?
Well, I've worked a lot with oncology patients in my career, and there's a role called the infirmière pivot en oncologie, and I always thought I would maybe try that one day. And I also wanted to move to like a part-time position, and my position is part-time. And this is more or less like an infirmière pivot, but in this sector. And I'm glad I made the move. So
we're very glad too.
Yeah. Well, thank you so much for telling us about your career and your work in endometriosis. And now just to also introduce things a little bit, for someone hearing about the word endometriosis for the first time, how would you explain what it is and also sort of what's happening in the body with endometriosis?
For sure. It's an important first question because it's not super well understood by the general public. So endometriosis is a condition that affects about 1 in every 10 women. Normally in the uterus, you have the lining inside, which grows every month and sheds as menstrual blood if there's no pregnancy. And this happens on a cyclic basis, which is normal. In some women, this same kind of tissue is growing outside of the uterus. So every month when they're having a period, they're also having kind of like a mini bleed inside the abdomen, where the small amount of blood is very inflammatory. It causes a lot of pain. It can cause scarring, cysts on the ovaries. It can cause lots of havoc inside. And it can be also very difficult to detect on imaging. So you have a big proportion of patients who are suffering with really bad menstrual pain or infertility or other problems due to this condition.
And what do we know about why it develops?
There are a lot of theories about why some women get endometriosis and others don't. We don't have a perfect understanding. It's probably some combination of all the theories, but some people speculate that when you have your period, there's a small amount of menstrual blood that actually goes backwards outside of the fallopian tubes into the abdomen. And that in some patients, this will sort of implant on the organs and sort of land there and stick there and continue to grow as lesions of endometriosis. This theory makes sense because we know that in some women who are born with a congenital anomaly where their menstrual blood cannot go out the normal route, they have a very high rate of endometriosis because they have a very high rate of sort of backwards menstrual flow. That being said, most women have some degree of what's called retrograde menstrual flow, but most women don't have endometriosis. So we know that it's probably involved in how it starts, but not why some women develop endometriosis, whereas others kind of just clear this blood and it's not an issue for them. There's probably an immune factor too that's involved, but research is still definitely lacking.
Okay. And now we know a little bit better about what endometriosis looks like as a disease in the body. What does it look like in the life of a person? And by that, I mean, how does it affect a person's life when it comes to health, when it comes to relationship, when it comes to work?
So, it, sorry, it can affect like various parts of a person's life, even daily bodily functions can be affected, like going to pee, going to pass stool. These can be very painful for patients. They may experience like severe urgency, frequency, a lot of endometriosis has been has been associated with other conditions like irritable bowel syndrome, like Dr. Zakhari said, infertility. Infertility, if you haven't lived through it, you won't understand it. Like any like couple or something like that, they want to have a child. They think it's going to happen just like that, but then it takes years and they don't know why, and it's not. Often it's not investigated until like it hasn't happened or they've failed multiple treatments. Also, it can cause chronic fatigue. So let's say a person, can't do the housework, but they can't explain why. Maybe their partner doesn't understand why. They think they're lazy. Like I've heard that from patients. That affects them a lot. And that can affect the mental health as well. Like endometriosis has been associated with higher rates of anxiety and depression. We have like this long questionnaire that patients have to fill out before we see them that has a lot to do with mental health. They often or always feel like their symptoms are ruling their life, that they can't control their symptoms. They often feel depressed, things like that. It affects a lot, not just the pain aspect. I didn't even touch on the pain aspect. They're dreading having a period every month. And often the pain is not just during the period, it's like off their period, like throughout their cycle. And sometimes conventional medications don't work. And so, it's not fun.
Yeah, to say the least.
Yeah.
Dr. Zakhari, you mentioned it affects 1 in 10 women. And Melissa, you said you've been reiterating how much of a burden it could be on somebody's life. Why do you think for so many women we don't know about this? Sometimes I often talk to people and it's the first time they hear about the word endometriosis. What is that? Like, what are some of the barriers that are in our way?
Yeah, that's a really good question. So it's a problem because it can be very difficult to diagnose, and so the diagnostic path for endometriosis is quite lengthy and difficult. So, and there's a lot of normalization of painful periods in society, and this is kind of a double-edged problem because we see it both from the patients and their families who are told it's normal. Like I also had painful periods as your mother, and you're gonna have painful periods, and that's just how it is, and they normalize it and they say that's okay, just take a Tylenol and continue. And on the physician side as well, doctors are often telling patients, periods are painful, like labor pains for having a child are painful. And so it's just normal pain and, you need to just sort of suck it up and move on with your day. So from the normalization from both of these sides, as well as how difficult it can be to diagnose, for sure it's really hard for endometriosis to sort of get the airtime that it needs in terms of research, mainstream media, public funding for research, that sort of thing.
Yeah, it's a shame that so many women go through this really heavy burden of dreading their period, like you said, and then thinking that it's normal because there's family history of painful period. It's just a thing, like they're just supposed to suffer. But to anyone who might be listening to this and might be wondering, what's going on? I would like to know more about this.
Like, are my periods normal or not?
Exactly. And I think it would be really useful if, are there any red flag symptoms that indicate that maybe there's something like more than just painful periods between brackets?
That's a really great question. And actually, we debate all the time, even in the circles of OBGYN, about what is a normal period. From a point of view of how much bleeding is in a period, we kind of have established ideas of what's normal for flow. But for pain, you'll have some doctors say periods should not be painful. And you have others who say it should be painful, but it can't interfere with your daily life. And sort of the definition we have kind of landed on, at least in our, small group, is, periods, it's normal that they can cause some pain, but that pain should be manageable with simple interventions like Tylenol, Advil, and maybe a first-line option like a birth control pill. And if it responds to that and patients are functional, they're not missing school, they're not missing work, they can go about their daily life, then we consider that okay. If patients are having painful periods that it's like they're incapacitated, they can't leave the house, they've tried they've tried their birth control pill, they've tried anti-inflammatories, there's no help, that would be a red flag. So we tend to define it as painful periods that don't respond to kind of a first-line approach to management.
And so oftentimes also, like endometriosis is maybe misdiagnosed, or there's a long winding path towards the final diagnosis of endometriosis. What are some of the conditions that it can be mistaken for?
Great question.
So a lot of women may have what we call primary dysmenorrhea. So that means periods that are abnormally painful, but we can't quite find an explanation for it. And that's often once we've already ruled out endometriosis. Other women may have painful periods because they're very, very heavy. So heavy periods tend to be more painful than lighter periods because the uterus gets stretched more with the blood and expelling the clots. And so that's very painful and inflammatory. And many things can cause heavy periods, even polyps or fibroids. And so it's kind of a feed-forward mechanism where the periods are heavier, then they get more painful. And there's a cousin condition to endometriosis called adenomyosis, which is sort of like when you have endometriosis in the lining of the uterus and the wall of it itself, which is also painful and I would say easier to diagnose than endometriosis, but also definitely a challenge. So there's lots of other reasons to have painful periods too. Endometriosis is just one of many.
Mm-hmm. I'll actually jump in with a question if you don't mind, Mina. I was wondering, Melissa, so as per your role, you greet a lot of patients who have gone through this winding path down to the diagnosis of endometriosis. Are there any patient stories or patient anecdotes that really marked you in terms of how long and how frustrating that path was?
For sure, like you hear many patients that have seen 6, 7 doctors before taken seriously. And they feel dismissed, they feel like no one is taking them seriously. Just thinking about that, it's really unfortunate for the patients because like one of the issues with patients with endometriosis is infertility, and those could have been like prime years if they had been investigated. The other thing is like, so that thinking about that also, I find if the medical community was more aware and did listen and take the patients seriously, maybe order some imaging, like just to check like why, and that could save a lot of healthcare resources as well, and patients' time. And when they come to our clinic, like I have the privilege and to listen to their stories. Like I have the privilege to take the time, and they're really appreciative of that. And like just writing down what they're saying, it validates them, and they really appreciate that. And we have a good team, so it's also very helpful. So yeah,
it's great to also.
Yeah.
I was just going to add, I'm happy you said validate, because I think that's one of the biggest things that they get out of seeing like the team at EndoCares is the validation of their symptoms, reviewing the diagnosis with them, saying like, yeah, your symptoms make sense. Like we see this. And a lot of patients will actually be like crying tears of joy that they're finally listened to, that they're, feeling respected, they're feeling seen, and that they're being taken seriously. So that validation is super important.
Yeah. It's great that your team puts really the patient experience in the center. and collecting these stories from the patients. I think that's where bettering healthcare starts from. So that's definitely really beautiful. And speaking of being on the path for better care for patients with endometriosis, today, what are some of the biggest knowledge gaps in diagnosis of endometriosis that still remain to this day?
I think, like Melissa said, a big part of it is ordering imaging earlier on. So it's not difficult, and I think a lot of it comes from normalizing period pain, which is, again, it's a complicated topic, but I think ordering an ultrasound, even ordering an MRI if you're concerned. I mean, we get MRIs on joints all the time, so I don't know why it's so difficult or inconceivable to get an MRI for pelvic pain as well. It's quite simple, but that goes hand in hand also with having the expertise in imaging, which I think is also an issue, because you have some radiologists who are very focused or who have extra training to look for the subtle signs of endometriosis, and you have this kind of I need to choose my words carefully.
Less familiar.
Yeah. So you have some radiologists who are very familiar with endometriosis and the subtle signs that it can present on imaging, and you have others that either lack the training or the exposure to this pathology, so they're not as comfortable diagnosing it on imaging. And so I think a big part of it comes from training our radiology colleagues or sensitizing them to what to look for on imaging. And also the better history we give them for why we're ordering the test will help them focus their exam too. So I think that would be one very big and important step forward for improving care.
You mentioned that you have an amazing team at the EndoCares clinic, and it's known to be a multidisciplinary team. And we mentioned how important radiologists, for example, are. Who else is on the team of your clinic?
So we have the gynecologic surgeons who are, present for every patient. We have, of course, Melissa, Shang, Leen, nurse navigator supreme. We work very closely with our radiology colleagues as well, especially for surgical planning and identifying lesions. We also have big multidisciplinary meetings where they're involved, we're involved, along with general surgeons who may be there if there's a bowel component to the surgery. Urology as well is often involved. We have fertility doctors, because often the debate is, should we start with fertility treatments and then do surgery after, or do we start with surgery and then do fertility treatments?
There's thoracics also sometimes.
Yeah, thoracic surgery too, and even pathology, which really helps us push the molecular or personalized aspect of the research in endometriosis.
Okay. I'm curious about the thoracic specialist involvement, because I always thought endometriosis to be like a really pelvic focused disease, but why the thoracic team?
Yeah, so we can see endometriosis in almost any part of the body, and often we'll find it on the diaphragm or rarely inside the pleural space or on the lungs. Okay. But not infrequently we'll find extrapelvic endometriosis, as we call it. So yes, it's usually in the pelvis, it's usually around the ovaries, around the rectum, but it can also be on the appendix, on the small bowel, on the diaphragm and liver. And so we've had a few cases of needing to remove a piece of that diaphragm in conjunction with thoracic surgery.
Wow. Or on the bladder too.
Yeah, absolutely, on the bladder as well.
And what does that correlate in terms of symptomology?
Patients will often complain of either shoulder pain with their periods. Sometimes they may even be coughing blood every month. Some may even have a pneumothorax, so sort of like a popped lung every month with their period, which is interesting because it helps us find the diagnosis a bit sooner for these cases. And they often respond well to some strong medication to block the period, and then their chest symptoms improve. And so that's kind of a rewarding response to see.
That's, yeah, go ahead, Ania.
No, it's okay.
So I was going to say, first of all, I think that's crazy. I mean, that means endometriosis is kind of like a lupus or a syphilis. It can present in any fashion, really. And how do you think, like, how because it's so general, what should we be telling the public, what can we do to guide them towards perhaps considering endometriosis in terms of not only the patient, but also the healthcare provider?
There's an organization called the Endometriosis Network Canada that has like a sort of like an awareness poster of like the 5 main symptoms of endometriosis. So like painful periods, painful defecation, urinary symptoms, painful sexual intercourse. And what's the other one? Wait. Dysmenorrhea, dyschezia, urinary symptoms.
Is it just pelvic pain?
Or
Non-menstrual
non-menstrual pelvic pain? Yes, I think so. Yeah, so those all, if you're having all those, like, that's, a sign maybe to get investigations.
In the old days, we used to say endometriosis can only be diagnosed after a surgery. You have to have a surgery. We take a piece of it, we look in the microscope, and we say, okay. But now more and more, there's been a paradigm shift over the last couple of decades where we say, just diagnose it clinically. So if, and we say if it quacks like a duck and if it swims like a duck, it's going to be a duck. So patients who come with these painful periods, with all the symptoms we described, we will presume it's endometriosis until proven otherwise. That way, we're not delaying treatment. We're not subjecting people to a surgery just for a diagnosis. We start treating them right away. And this is also, it's been reiterated very recently, actually just this month, the American College of OBGYNs published a new clinical practice guideline talking about the empiric diagnosis of endometriosis, which is a big step forward, I think.
Mm-hmm. It puts a voice finally on all those patients who couldn't advocate because you need a surgery for diagnosis, but no, I'm hurting. I know there's something wrong. It's a great step.
Exactly.
Yeah. And
I forgot to mention about the painful intercourse, about the question you asked earlier about how it can affect their life. And so that's a big issue as well. That's supposed to be a nice time and whatever. And sometimes they can't because they're in so much pain. So that's,
yeah. That's something that definitely can affect someone's life in a significant way. And I guess, and also with relationship-wise. Yeah. And we've talked about how endometriosis is a really multidimensional disease, how it affects, even if it's mainly a pelvic disease, how it affects really the whole body and a lot of different aspects of one's life. So I'm guessing a lot of endometriosis patients require multidisciplinary care, which is the goal of EndoCares, of course. And I'm just wondering, in general, in Quebec or in Canada, how much would you say that the model of multidisciplinary care is accessible to patients battling endometriosis?
I would say not accessible at all.
Oh, so we've got work to do.
We have a lot of work to do in Canada.
Yeah.
And we look up to other countries that have made sort of national action plans for endometriosis. Mm-hmm. Countries like France and Australia, who have really made a concerted effort to call this a priority and to throw resources at it to try and improve the outcomes that they're seeing. For example, basic things like physiotherapy. I mean, we have physiotherapy for joint pain, for back pain, but we don't have pelvic physiotherapy, which is a type of physio specifically for patients that have pelvic pain or other pelvic issues. And we know that this is fundamental to the treatment of pelvic pain, particularly painful intercourse, like Melissa was mentioning. And so one thing would be, more public, any publicly funded pelvic physio would be a great step forward. That's something we're working on currently in our clinic, but it's a slow process. And the other one, which Melissa also touched on, was the mental health support. So we know that endometriosis comes with a big mental burden as well. We see a lot more mental health conditions in patients with endo. And so having this necessary psychological support is super important. And that's something that we're working on as well. And we're in our final steps now of launching. So there's a lot of work to be done 100% across Canada.
Yeah, we're hoping to support all that work.
For sure.
This is a great step forward too, so we thank you for taking the time to shine a light on this.
Yes.
Thank you for being on. So you were talking about, accessing care, and of course in Quebec, it's not the best, perfect healthcare system. A lot of people lack family doctors and maybe don't have a doctor at all that they can see. And then, of course, we talked about how EndoCares sometimes usually works by referral, from what I understood. So if there was somebody who, for example, didn't have access right away to a family doctor, but suspected that they had endometriosis, what would be your recommendations to them to access that care that they need?
Unfortunately, right now, patients that don't have family doctors in Quebec, they need to access the guichet accès première ligne, which by personal experience, it's not great. You have to really push your case to get an appointment. So it's really hard. But if you're able to get an appointment, then you explain your symptoms. It's not easy. We don't have the best. It's hard.
Breaking into the system is really difficult when you don't have a way in. But like Melissa said, you try and get an appointment with a nurse practitioner, a family doctor, sans rendezvous, some sort of way to get in and try to get some imaging. I would say that would be the first step. And even while waiting for that, patients who are suffering, they don't need to delay treatment, so they can also look up themselves what kind of treatments they might be interested in for endometriosis. There's lots of resources like on the Endometriosis Network Canada that kind of go through the basis of the medical management, for example. And while we're not suggesting people go out and chat GPT their entire prescription, but it's a starting point. So it opens a dialogue with a practitioner who can help them. And if they want to try something simple, if it's safe for them, a birth control pill, for example, that's probably a safe first line for most patients with these symptoms while waiting to sort of get their imaging, get their referrals in.
Mm-hmm. You mentioned the gap. Could they also do it through the 8181, or does it have to be a little bit more?
Well, I guess they could speak to a nurse but by Info Santé, and then maybe, I'm not sure if they're able to book appointments for patients. I'm not sure, actually.
Okay, interesting.
Yeah.
But it's worth a try, I guess, for anybody who would need.
And in light of all of this, because I know that you both have very insightful advice to share about this, do you have any advice for the medical students that are listening and learning how to care for patients in how to manage endometriosis diagnosis and also just like follow-up management overall?
I think what's really interesting from a medical student's point of view, which doesn't feel like that long ago for me, even if the numbers are are saying otherwise, but in medical school you learn a lot about the condition, like the presentation, the test to order, the first line management. You learn a kind of very cut and dry, cold kind of fashion. But when you start to meet patients with the conditions, I find it so much more interesting to see, kind of like how Melissa was describing, how does endometriosis present in a patient's life. So when you see that infertility patient with endometriosis, or you see that patient with, the incapacitating periods who is now, like, let's say back at work or back at, doing sports, so I find the most gratifying part of medicine is seeing the clinical presentation of a very scientific and medical problem and how we sort of coax it into a better quality of life for patients. So I would advise medical students to really look for good clinical exposure all the time, whether it's for endometriosis or another condition. Not only does it help you learn and remember things, but it also kind of gives more meaning to just a generic pathology in a textbook.
I would say, like, say you're taking the patient's history, like an endometriosis patient, like, take that extra 10 minutes, like, just to listen. It's gonna, like, be very validating for them and make their appointment much, much better that you're taking the time to listen. I know it's not always possible, but just 5-10 minutes more before seeing the next patient, it can help.
That's such a valid point, because I feel like in medical school we teach us so much to look for the diagnosis, checklist. I did this test, I did that.
And sometimes we're thinking more about the checklist than the actual patient.
Yeah, like, how are you doing? It's just, Yeah.
And when you're busy, you'll find that it's really hard to keep up. And then some patients will say, like, you've asked me that 3 times now. And it kind of, it snaps you out of it. It's like, I'm sorry, like, I'm going to put my pen down, or I'm going to, like, look away from the screen. And then you end up having a shorter appointment the more attention you pay to a patient.
So the MUHC EndoCares is an amazing project. Well, it's probably like very late, but congratulations, I guess, on founding it. It's one of the big advancements that we have in endometriosis care in our healthcare system. What are some other advancements that you're very excited about?
I think we've had, in the last 10 years, it's actually been amazing how many new medications have come out in gynecology specifically. And I don't know if it's just a bias based on when I graduated, but I find that we now have so many more options, not just for birth control, but for hormonal replacement, for managing endometriosis or fibroids or heavy bleeding. So I think there's been like a big resurgence of interest in developing new medications for gynecologic conditions, which I think is great. What's I think lacking still is non-hormonal medical advancements. So all of our treatments tend to fall in the umbrella of hormones, more or less. But we know that endometriosis is a very inflammatory condition and it has a big immune component. And so we're still holding our breath for some new breakthrough medication, which will either be, an immune or inflammatory sort of based treatment as opposed to a hormonal based one. It makes sense to target hormones. It's a hormonally driven condition. But I think we're still lacking a bit of that variety in our medical armamentarium.
Yeah, and there are patients that, for various reasons, don't want hormonal
Hormones,
treatments. Yeah.
Right. And Melissa, you spent over 20 years in the field of medicine in general, and I guess seeing the evolution of endometriosis. What do you think has changed in a good way over the years?
Related to endometriosis?
Yeah, or medicine in general, if you'd like to broaden the topic.
I find like just our small team is trying to raise more awareness about it. Like I think in the last maybe 10, 15 years that it's gotten more awareness. Like I know Dr. Zakhari, Dr. Nguyen have spoken to the government about endometriosis. Like our team has tried to do some projects sometimes to raise awareness during Endometriosis Awareness Month, which is in March. But I think there's a lot of work to be done. Like the other question about what multidisciplinary team, like ideally we could have other complementary therapies other than pelvic physio, like things that help, like osteopathy, acupuncture, like all those things are other ways that patients help to manage their symptoms, but they're all in the private sector right now, and a lot of patients can't afford that, even with insurance coverage. So it's, that would be something to look at in the future. Yeah.
Can I build off what Melissa just said?
Yeah, of course.
Yeah.
I'm so sorry.
No, I just thought of
No,
something.
you can't.
I forgot about nutrition. Nutritional changes can also help with some symptoms, because a lot of endometriosis patients get endobelly, which is like they look pregnant, like when they're on their period or whatnot, and sometimes the bloating can be helped, and also other digestive symptoms with nutritional changes. So, yeah.
I think what's great is we have a lot of expertise in Canada, in Quebec. We have a lot of expertise in physio, in nutrition, in psychoeducation. We have a lot of surgical expertise. We have a lot of the building blocks that are necessary. But I think what's really lacking is a sort of organized and systematic approach to the funding and delivery of this care. So if we can just find a way to get the government to prioritize it, to budget for it, to get us the OR time, to get us the complementary therapies, if we can get this all put together, then I think we can really offer world-class endometriosis care to a very broad community. But as it is right now, we're doing our best with what we have. It's always a bit of patchwork, and there's always things that we can't fully offer in the public sector, as Melissa mentioned, and so it's unfortunate, but I think that would be the one next big step forward again, would be assembling all this expertise in a more cohesive way.
Yeah. And in light of everything we've discussed, because we've talked about a lot of things, we talked about what endometriosis is, what are some red flags of diagnosis, how it affects one's life, and also what's left what work is left for us to do in the field of advocacy and everything. But in light of all of this, do you have a key message to anyone who might be listening about endometriosis advocacy and recognition and diagnosis?
I would say to healthcare professionals is to take a patient seriously, like invalidating painful periods. It's not normal. Like it affects a person's life in different ways, and just listen, just go a bit further, order that test or that could change a person's life or their next many years of life, for them searching what's wrong. So that's my that's my 2 cents.
And you spoke to the healthcare workers. Also, I'll speak to the patients then, which is, to not give up, to keep hope, and that there's always more. There's always more light at the end of the tunnel than you think. And so I think we've made big strides slowly, but we're making them. So to continue the fight, to continue advocating, seek the help they need, and to just keep it up. They're doing great.
For anybody who wants to get involved in endometriosis advocacy or campaigning, what are some of the things that maybe events that they could look forward to?
There's two good organizations that are doing a great job of rallying patients together. One is the Endometriosis Network Canada, and the other one is Endometriosis Quebec, whose website is, I think, just that, endometriose.quebec. So those are great places to start for patients that want to get involved. There's always Facebook support groups as well. And we ourselves try to do fundraisers from time to time. We're involved with the Beneva Marathon in the fall, so we're going to get training for that.
An opportunity for anyone listening.
Yeah.
You can sign up. It's happening in September, I think, this year. Or October
maybe?
it's this
I think
year.
it's October.
Yeah.
I think
October
there's
7th.
an endo walk also every
Yes.
year, and they have some other advocacy things on the Endometriosis Network Canada, where there's like a pre-written letter that you can write to your MP or provincial representative about endometriosis, and make them more aware that it costs Canada and Quebec a lot of money per year because of frequent medical visits and things like that. Yeah.
And the other thing that people can do is support organizations like WHAM.
Yeah.
Like WHAM is doing a great job, and so
doing great.
Yeah, anything that can help WHAM is helping everybody.
Thank you, Dr. Zakhari. Well, thank you so much, Melissa and Dr. Zakhari, for being guests on this podcast. We really appreciate hearing about your expertise and
We learned a lot.
learning
Yeah,
about so
yeah.
much about endometriosis and sharing your knowledge with the public as well. I guess we'll wrap it up here for the
Yeah.
podcast.
Thank you to everyone listening. I hope that you enjoyed this episode and that you learned a lot like us.
Thank you guys so much
Thank
for having us on. It was a
you.
pleasure.
Yes, thank you so much.
All right. It's perfect.
Yay!
Naturals.
Yeah.
Sorry, I'm getting over a cold. I always have
No stress.
Oh, good. It's nice raspy. It has texture.
Endometriosis.